Hello, listener. This is The Way In, a podcast about finding our way through the often impenetrable worlds of psychotherapy, psychiatry, and psychoanalysis. I'm your host, Tyson Connor. I'm a psychoanalytic psychotherapist and clinical supervisor in Washington State. Each episode of this show, I talk with other mental health professionals about the work they do and topics they care about, using language that you don't need an advanced degree to understand. Come join us as we try to find the way in. And today, my guest is Dr. Matias Massaro. Mati is the founder and owner of Cognia Health. You have your PhD in psychology and are now finished with a second PhD in psychiatric prescribing, correct?
So that's where it gets confusing because I come from another country.
Right.
And our credentials change from country to country. So I graduated as a psychologist in Argentina. And then I moved to the US where I went to nursing school for my psychiatry nurse practitioner degree, where I finished the whole program with a doctorate in nurse practitioning. So
Correct.
It's very confusing. So the best way I can sum it up for people is that I'm a psychologist and a nurse practitioner specialized in psychiatry.
Great. Right. And you run Cognia Health, where you provide psychiatric prescribing through a psychotherapy lens, or at least that's what it says on your website.
Yep.
And today, Mati is going to be our guide into psychiatric medications for ADHD.
Yeah. It's a good topic. It's interesting. It's fun. And it's something that a lot of people have questions about. Not only this is a diagnosis that has been resurfacing as something where more people are getting educated on its presentations, which has led to more consults, questions, and, basic intrigue about like, hey, if I feel a certain way or if I'm diagnosed a certain way, what are tools that could help me feel a little better or feel a little more in control based on the impairments that these may be causing?
Yeah. So listener, if you're curious to hear a more broader conversation about medication management on the Relational Psych podcast, we did an episode on that. So go back and listen to that for the broad overview. Today we'll be focusing in specifically on ADHD and the various meds for that. So let's start with the sort of broad overview of what ADHD is.
Yes. So ADHD stands for Attention Deficit Hyperactivity Disorder. Long story short, is a neurodevelopmental disorder characterized by a consistent pattern of inattention and or hyperactivity or impulsivity that interferes with daily functioning or development for at least 6 months. So what does this mean? Let's break it down, right? Neurodevelopmental. What is this fancy, complicated word? It means that symptoms start when we're little. They onset, they present when we're a child, typically before age 12. Now, the DSM, which is our diagnostic manual, right now has a strict mark on age 12, but the research is a little mixed, and they ended up with, we have to put a number somewhere and we put it there, but it's not set in stone. The most important part of neurodevelopmental is that it starts during childhood.
And I think most of our listeners will be familiar with ADHD, broadly speaking. A couple things that I want to hallmark for them. One, ADHD is one of the things that falls under the broader category of neurodivergent or neurodiversity, right? It's about a different kind of brain, kind of is a broad way of speaking about it. It's about a way a brain functions on a very global level. And it doesn't appear to be a diagnosis that is like traumagenic.
That's right.
Like it's not that something happened to you to make you ADHD, just like some people's minds just function this way.
That's right.
And then the other thing that I'll hallmark is that you might have heard of ADD That was what a lot of kids were diagnosed with when I was younger, was ADD. And we don't talk about that anymore. There used to be, I'm trying to remember, I was never trained on the DSM-4, but ADHD and ADD were treated as separate diagnoses that then got folded in together. So
Yeah.
some people still use the older terms, but prescribers will just talk about ADHD anymore.
And essentially, they will somewhat merge, like you were saying, but then we have sub-specifiers dividing them again between an inattentive presentation, where these are folks that they meet most of the diagnostic criteria for difficulties with attention and distractibility. You have a subvariant of hyperactivity impulsivity, and some folks lean towards that side more than the inattentive. And the third type is that combined presentation that has a little bit of both, if that makes sense.
Yeah, and I think when people think about ADHD, they tend to more think about the hyperactive and impulsive side. Like when you imagine a child with ADHD, the image that comes to mind for many people, including me, is like a kid who can't sit still, right?
Yep.
A kid who's like really active, a kid who's really moving around a lot. But that's really just one presentation out of the three. The other presentation, I've worked with folks who were predominantly inattentive ADHD, who were improperly diagnosed as being severely depressed.
Yeah.
Because the presentation can be really similar. There are these folks who, children or adults, who just like their minds have difficulty staying focused on whatever's right in front of them, or in a classroom or in a work setting. And it can seem like they're dissociating because they're super depressed or have really low energy or aren't following along or aren't performing well at school or at work because they're really sad or something. And then when you actually have a conversation with them, or when you actually like sit down and think about it, it's like, well, actually, no, they're not dealing with some major depression. This is just how their minds are working right now. This is just what's going on in there.
There's a lot of that. There have been myths and misdiagnoses with this theme many a times, because you're right. When traditionally and historically in the mental health model that we've had, I think most people's minds, when they think of ADHD, they think of that hyper, particularly boys. It's been that hyper monkey-like boy likes to run and climb around, very energetic, when we learned that can be, a specific symptom or two of ADHD. But the more we've learned about it, we learned more about the theme of ADHD and how it can present across the sex and gender spectrum, across ages, and how it can be mistaken for other things such as depression, bipolar, even borderline diagnosis disorders and other things, where in fact it can be better explained by ADHD-like presentations, which once we apply specific behavioral and or pharmacological treatments, we start seeing a lot of improvement.
Yeah, and that's why diagnosis, although, diagnosis can get a bad rap in some settings and can be used in some pretty harmful ways. But for stuff like this, diagnosis can be really important, because diagnosis will tell you like what it is you're actually trying to target. Because if someone's depressed, the treatments that are recommended are very different for someone who has inattentive ADHD. And the wrong treatments can sometimes, at the very least, you're delaying someone getting better. And at the very worst, especially with this category of neurodivergent, it can be really easy to pathologize and lead to someone feeling like, oh, there's something fundamentally wrong with me, I'm broken. And that can lead to depression and things like that down the road. So treating depression too early and too hard can lead to causing worse depression later, turns out.
Yeah, we've actually, unfortunately, with a little bit of fortune there, we unfortunately learned a lot about the negative impact that missed or undiagnosed ADHD can have. The fortunate part is that, now we can make a difference. But yeah, there were a lot of folks who have, and still do, grow up undiagnosed or untreated. And these symptoms can be impairing to a degree that developmentally can impact people pretty strongly. I'm talking folks who develop depression or anxiety, like you mentioned, social anxiety, rejection sensitivity, and even trauma-like presentations. We see how the impairment related to these symptoms or presentations can lead to a consistent and prolonged inner dialogue or monologue of low self-esteem, or thinking incorrectly that they are dumb, or that they have a poor memory, or anything that can lead into spiraling into negativity, which, if we do it for a few minutes, it's okay-ish. But if you do it every day for years, especially your developmental years, look, it's going to be hard. So it's one of those things that, the sooner we can do it, the better. And it is why it's one of my favorite things to work with, because most of the folks we work with say the beautiful, lovely words, which is, oh, man, I wish I'd done this earlier. Which, look, there's pain behind those words, because there's a sense of loss of what could have been with being diagnosed earlier. But it's also so amazing that diagnosis and treatment can have such an impact for people.
Right. Yeah. And while we're talking about that, I think talking specifically about ADHD meds, part of the reason I wanted to do it is because we did an episode on the previous podcast about SSRIs, right? Which highly
Castles
recommend.
and pigeons.
Castles and pigeons the whole way through. It was great. Which are one of the most common forms of psychiatric medication to prescribe. And I really wanted to talk about this one because there can be a tendency to overdiagnose ADHD, especially in kids, right? That is absolutely a thing that happens. Kids get diagnosed with ADHD when, in the same way that you can diagnose someone with depression when actually it's an attempt of ADHD, you can diagnose a child with ADHD because of their hyperactivity, which might actually be traumagenic. There could be trauma stuff happening at home that's leading to these behaviors. And ADHD medications are highly effective treatments for ADHD. And so a lot of folks who are misdiagnosed as ADHD are given these highly effective treatments for the wrong diagnosis. So part of the reason I wanted to do this episode was in part to try to destigmatize ADHD medications, broadly speaking, because when you're working with the right diagnosis, I've seen on the practitioner side with adults and with children how powerful the shift can be, right?
Yes.
That statement of God, I wish I'd done this sooner. Or the thing I've heard from kids, which is I feel like myself, or rather,
that's right.
It's I feel like I am myself all the time now. I don't feel like something takes me over anymore.
Yeah.
It's so liberating. It can give children and adults this incredible freedom. So I wanted to try to demystify some of this to make it a little less scary.
Yeah. And in fact, this happens a lot, Tyson, where I see many adults who come, let's say, apprehensive, a little reasonably frightened, because when they were young, they may have had a poor experience with these medications or with psychiatric treatments in general, right? So they tell me, look, man, I'm here because life has gotten really hard for me and I need help. But it can't be like it was last time.
Yeah.
And fortunately, we figure out ways so it's not like last time. Not only their bodies and their lives have changed, but medications have changed. We have now a history and a record of what hasn't worked before. So we are better set up for success now in adulthood, where they are more in control of their lives, to figure out a treatment that can be life-changing.
Yeah. And it's so good, you guys. These medicines can be so good. Okay. So let's talk about them.
Yeah.
What are the primary categories of medications available to treat ADHD?
Yeah. So it boils down to two categories. These are two big families that we are going to go a little more in detail, but the main two are stimulants and non-stimulants. These are the two big ADHD families. Let's start with stimulants because these are the first line of treatment.
Okay.
What does first line of treatment mean? They are decently tolerated and they are the most effective. In fact,
When you say decently tolerated, what I understand you to mean there is most people can take them with minimal side effects.
that's right. Yes. And in fact, this is one of the medications in psychiatry, maybe in general, that has the strongest effect size among all of the research that we've done. In other words, we've studied many medications, and medications can improve symptoms to a degree, some to a small degree, some to a big degree. Stimulants have what we call a very large effect size, which means that when we studied them, they make a big difference. They are very good at what they do compared to other medications that, some are okay, some are better, but stimulants, they are an MVP in that team.
Yeah. So for the listeners who might not have taken a research design class ever or statistics, effect size is essentially, as I understand it, I want to make sure I'm remembering this correctly as well. Effect size is like how much of an outcome you can likely attribute to a specific cause, right? So like if you have two teams who are playing a baseball game against one another and one team has an incredible pitcher, but they also have a like mascot that's a cat. And then you do a statistical analysis of the game or come up with some like way of testing what's going to produce that team's going to win the most. The incredibly excellent pitcher factor will have a larger effect size because a very high performing player has significant impact on whether or not a team wins a game.
Yeah.
And whether or not their mascot is a cat probably doesn't have as much of an impact. It'll have a lower effect size. That might be a bad analogy, but that's what I'm going with.
No, I think it's great. And yes, they are very strong players, which is amazing. And the fact that we can decently tolerate them is even better, right? So that's why they are first line of treatment. So
what also feels important to note is that like in the world of medications, psychiatric or otherwise, people heal or recover or change based off of lots of different factors. And so having a medication with a large effect size is really meaningful.
yes.
Like we've kind of talked about this in the past, the idea of the placebo effect. And that like the placebo effect is present and doing its job of like working with every medication that someone takes.
Yeah.
If you believe that something's going to help, it will to a certain degree. And so having a medication with a really strong effect size is like really great and really hopeful in the world of prescribing because it means that the medication is very directly targeting the thing you want it to target. Human bodies and brains are very complex things, and a single chemical change usually makes a difference, but making a big difference is rare and great when you can find it. All right, you were saying.
Oh no, that was great. And the way I see it sometimes, and the way we talk it with clients or patients, is we're working with an advanced Jenga right now. Every little piece we may affect can have an effect on everything else. So I like the way you put it because it is that way. Everything's connected to each other. So the main thing that these medications do are work through dopamine and norepinephrine. These are neurotransmitters. These are molecules that are messengers that communicate between neurons, right? So these neurotransmitters, particularly dopamine and norepinephrine, they are very important for attention, concentration, motivation, and the reward system, among other things. So these medications either increase the availability of dopamine and norepinephrine by stimulating neuron A to neuron B to create more of these neurotransmitters or release more of these neurotransmitters. and or that when those neurotransmitters are flying from one neuron to the other, flashback to the pigeons, the recollector, the reuptake inhibitor, is affected so that there are more pigeons or more dopamine and norepinephrine available for the second neuron B to pick up.
Gotcha. So in the SSRI episode, we talked about this analogy of neurotransmitters functioning kind of like carrier pigeons or messenger pigeons being sent between castles, where each castle is sort of like its own neuron, and you're sending out a bunch of these messenger pigeons, and enough of them just need to make it to the other castle, but a bunch of them will get lost along the way, and it's a complicated system. And for SSRIs, selective serotonin reuptake inhibitors, we're talking about serotonin. But today, with these stimulants, we're talking about different chemicals. We're talking about dopamine and norepinephrine, which, as I recall, dopamine is what we primarily associate as like reward loop kind of chemicals. Dopamine is the chemical that, again, maybe hyper simplifying it here, but so be it. Dopamine is the chemical that's like, oh, that was nice. Oh, I like that. Oh, that was nice. That's dopamine. Norepinephrine is a little bit more energizing, as I understand it. It's a little bit more like engaging. It's something that your body releases when you're engaged in something that you're really like connected to and you're feeling into it. So norepinephrine will be firing when you're like super into solving a crossword puzzle, or if you're playing a basketball game, right? And you need to pay attention to where your teammates are, right? Norepinephrine is the thing that's getting your brain to put together the pieces that's around and focus, connect, talk. And so what I'm hearing you say is that the stimulant drugs, so the mechanisms for the stimulants is primarily that focused around dopamine and norepinephrine. Essentially, again, making reference to that episode where we talked about SSRIs. Listen to it, listener. I'll link it in the show notes. It's making sure that there's a lot more of those messenger pigeons, those neurotransmitters being activated in a person's brain, just sort of upping those particular chemicals.
Yeah, that's right. And particularly, we want more of these neurotransmitters, dopamine and norepinephrine, in specific areas of the brain. To simplify it a little bit, the two primary areas that we want to look at are the prefrontal cortex and the basal ganglia. These are areas that are very, very involved in executive functions, like decision-making, impulse control, rewards, like you said a minute ago, motivation, and emotion regulation. So what we've learned through a lot of research and scans is that folks who meet the criteria for ADHD tend to have a hypoactive or underactive prefrontal cortex and basal ganglia areas, which, if we stimulate and activate them, pump them up a little bit more, they can start doing their jobs better. Let me tell you about an analogy that I often use. So imagine if the prefrontal cortex were the brakes of the car. Okay? And the brakes are maybe not working as intended or not working as we hope to. So it's hard to drive the car consistently and turn by reducing speed or doing things that require maneuverability, right? Now, if we address the brakes, if we stimulate them so that they can work better, we can actually help the car slow down. So when folks who meet the criteria for ADHD tell me, I have like 10 tabs open, 4 are playing music and 2 are frozen, I don't know what's going on, man. By stimulating these brakes, the prefrontal cortex, we can allow them to regulate everything else on the brain. What do you think?
Yeah. We did on the Relational Psych podcast. I did an episode with Dr. Bailey Hoey, about executive functioning, and we talked about what a big category that is, right? Like executive functions are really, there's a lot involved in that. Your executive functions do a lot of things, and I think the brakes analogy is a really good one, because like I remember when I was a kid and when I first was playing like racing video games where you could like upgrade your car, all I wanted to do was like be able to go faster, quicker, acceleration and top speed. That's what I was on about. And then you'd get to a track that was twisty and windy and curvy, and all of a sudden the fact that I hadn't invested any of my credits, because I was playing, Star Wars Episode 1 Pod Racer, and I hadn't invested any credits into braking or handling, meant that I lost every time because I was crashing at every corner. And human life is not like a drag race, usually. Every now and then, there are times where you want to like hyper focus and just get on a thing and go. But most of what human life is very complex. We're doing a lot of things at once. Mostly we're not racing. We're just trying to get from point A to point B. And so having that ability to slow down, to take a turn without losing track of where you are, is pretty important.
Yeah.
This feels like a place where it might be helpful to note whether or not you have ADHD, most human brains enjoy stimulants.
Yes.
Human beings like to use stimulants. Caffeine is a stimulant. Nicotine is a stimulant. Cocaine is a stimulant. Those have varying degrees of potential harm if used incorrectly. And human brains, broadly speaking, enjoy them some stimulants. And some of these effects that we're talking about, a neurotypical brain will also experience some benefit from, potentially, by taking some of these drugs, right? Like famously, the military makes use of stimulants for fighter pilots and people in other positions so that they can like perform the tasks given to them and like at the level that's being asked of them. Also famously, a lot of ADHD meds can be abused by people who don't need them in college to try to finish a paper on time or something. And I imagine we'll get into it a little bit later about what can happen when you misuse these drugs.
Yep.
But it just feels important to note, like, this category of drug, it kind of feels good to most human brains to be.
Yes. And folks will experience it different, like you're mentioning. So what's funny about this is when I'm working with folks who do meet the criteria for ADHD, and we mention stimulants, most of them are somewhat thrown aback.
Yeah.
Because they tell me, dude, my head already goes 1,000 miles an hour. What do you mean? We're going to make it faster? We're like, okay, just hear me out. We're going to make an area faster. And that area is going to be the brakes so that everything else can slow down. So what's the difference with, let's call them neurotypical folks?
Sure.
When it comes to neurotypical folks and their quote unquote brakes are functioning at an average baseline, when stimulants are taken, they experience, we're talking about taking an appropriate small amount of stimulants. I'm not talking 100 grams of cocaine. I'm talking about a standard little pill that would be used medically in appropriate people. But when misused by a neurotypical person, they notice a minimal benefit, because they do. And we all love positive feelings and emotions, sensations.
Yeah, it feels good to feel good.
What most people will describe is that now they can go a little faster. They can hyper-focus on that jet pilot situation. They can hyper-focus on this and performance or this, go faster, be sharp and effective and get this done. Now, here's the thing. Most people who meet the criteria for ADHD and take a stimulant, they don't describe that at all. They describe, dude, the noise went down. The tabs are now in an easy overview. None of them are frozen, and I paused the music on the ones that were on. things somewhat feel way more manageable than going into hyper mode.
Mm-hmm.
So both kinds of people will notice a benefit, but neurotypical folks might notice a 5% change that's very specific, whereas folks who meet the criteria for ADHD will notice a tremendous and large percentage difference.
Mm-hmm. Yeah. Yeah, so we've talked a little bit about stimulants and like the mechanism and how they work and how they work in neurotypical versus a neurodivergent brain. Let's talk a little bit about like timelines here, because when we're talking about SSRIs, we're talking about the impact of that is largely a downstream one. It takes a long time for it to kick in, but stimulants aren't like that.
That's right. So one of the good things about stimulants is that they are fast. Now, that doesn't mean that there are no downstream effects, because there are. The difference is that while we have those downstream effects where the dose and the medication will continue to adjust for an optimal response through a period of weeks, the immediate response, the initial response is same day. We're talking about people will notice the effects of a stimulant the first day that they take it. Compared to an antidepressant or other kinds of medications, it's a beautiful thing to say, where we can provide some relief to folks now with the potential for even more benefits down the road while the dosing and the body are adjusting.
Yeah, and that's one of the things that I often tell to clients who are concerned about medication specifically for ADHD, because maybe they've already tried an SSRI, and especially when you're talking about younger folks, it can be like oh my gosh, do I have to get them to take this pill at the same time every day? Especially if your executive functions are already a bit of a mess, that can be scary. But so it's great to be able to be like, no, like you take it when you need it and you'll feel it pretty soon. It's a lot more like taking like an aspirin or something, right? It takes a little while for it to kick in, and then the effects are present for a little while, and then they go away.
Yeah.
All in the course of a single day, usually.
Yeah. And in fact, we do have things to even smooth that response within the day as well. So there are medications where, if taken with or without food, can be experienced differently. Their speed, the time to peak in concentration, the duration of the medication throughout the day can change, whether in cases that we take it with food or without food. So it's typically a specific or a case-specific situation where we say, take this one with food, take this one without. But overall, most of them are better tolerated and they work a little bit better if we take them in the morning with some food.
Yeah, and it's kind of like if you're a caffeine user, whether that's coffee or tea, you might have experienced that. If you literally just have a cup of coffee in the morning and that's it, chances are you might notice it's a little bit more intense. It peaks a little bit sooner and is a little bit higher. Whereas if you have your cup of coffee with a full meal, you'll still get the stimulation. You'll still get that extra perk, but it won't be quite as intense and it won't be quite as quick. You might be a little bit less jittery.
Yeah.
And as I understand it, the main reason that the recommendation is to do it early in the morning is so that the stimulant is out of your system by the time you need to go to sleep.
Yeah, that's right. Because among different possibilities for side effects or adverse reactions, there are 3 that can be the most common, and one of them are sleep dysfunctions. So the way to prevent them or mitigate them is by taking these medications when we wake up with a little bit of food. I typically recommend folks to put it with their toothpaste or with their coffee or breakfast stuff, their morning routine, so that we take them when we wake up, use the benefits of the medication throughout the day, and expect it to wear off as much as possible by nighttime to prevent the stimulant from contributing to insomnia.
Right. And I know that for some stimulants, there are some of the pills are actually manufactured in a way that there's the extended release
Hmm.
version, which just as I understand it, it's the way that the pill is actually like built. It just your body processes it like a little bit more slowly throughout the day. And that's another thing that can be played with because I've known some people who the extended release version sort of helps keep them a little bit more level throughout the day, and it's great. And for other people, whenever they take the XR version of a pill, their insomnia is super bad, so they just take the regular kind. So
Yeah.
there's other ways that can be played with.
Those are good examples. And yes, typically the first line of treatment is an extended release formulation of these
Mhm.
medications so that they have a gentle curve lasting throughout the whole day, giving that 9 to 5 or 6 coverage and preventing an immediate or aggressive or abrupt sensation of a stimulant coming in. Because
Right.
that aggressiveness can feel uncomfortable,
Mhm.
but the extended release are typically what most folks take and what most folks find the benefits for. In some of the cases, like you mentioned, they are a handful in general. There might be situations where we might prefer an immediate release medication.
Mhm. Yeah, and I think this is another point to say, listener, if you're, you know, considering taking these meds or are taking these meds and are noticing side effects, talk to your prescriber because there's a lot of things
Yeah.
that can be played with to make it a better experience for you. Okay, so speaking of adverse effects, sleep
Hmm.
dysfunctions, that's a common one. What are some of the other more common
Yep.
ones?
Another common one can be appetite suppression.
Yeah.
Okay. This is another reason for us to use extended release formulations that can be gentler
Mm.
to prevent or mitigate the appetite suppression. Most folks probably note slight decrease in appetite. Now, most of them do notice that, but they tell me, I'm still eating fine. I'm
Yeah.
still eating the same amounts. I notice that maybe I'm a little less hungry, but I'm still having meals and snacks. It's only in very, very rare situations where the appetite suppression is strong. And
Mm.
people may tell me, dude, it's been 2 days and I'm not hungry. Oh, well, we kind of need the food and water, man. So
Right. Yeah.
we're going to have to do something about this. But
Mhm.
most folks either don't notice it or notice a minor appetite suppression, especially in an extended release version,
Mhm.
that can be worked with.
Yeah. Yeah, and again, that's a symptom or a side effect that's common to stimulants. Again, if you're a caffeine user, if you've ever been a nicotine user, like these are things that famously suppress appetite as well as keeping you up.
Yeah.
Uh,
And there's one more
mhm.
that we have to be mindful and that we assess for when we first meet someone that may start treatment for ADHD, which is blood pressure on heart rate.
Mhm.
Because these stimulants are non-specific. What does this mean? They have a little bit of a shotgun approach, which means they will affect the prefrontal cortex, the basal ganglia, and they will affect other areas as well,
Mhm.
which means that our regulation centers for the heart and for the cardiovascular system in general will also be slightly affected, leading to an increase in blood pressure and heart rate.
Mhm.
Now, this sounds a little scary, right? What we've learned is that most folks without a history of cardiovascular concerns or diseases do perfectly fine on stimulants.
Mhm.
And even those who have a history of cardiac concerns, it might require us to be a little more careful, gentle, to monitor things a little more closely, maybe to do a few more tests and follow ups, but it doesn't have to exclude them from taking one of these medications. It might take us a little bit of, extra steps, if you will.
Mhm.
But many, many times, if not most times, it's not something that would exclude them from these medications, especially when we do, a risk benefit analysis.
Right. Yeah. And this again, this is a common side effect of stimulants of all kinds, right? This is
Yeah.
why on cans of energy drink it says like don't drink this before exercising, right? Because and people have like had genuine like cardiac trouble from overdoing it on energy drinks and similar things before going to play a game of basketball or whatever.
The good thing is that we have recent research from these last couple of years that has shown most of the time that long-term use of stimulants does not lead to poor cardiovascular outcomes. So despite the possible elevation of heart rate and blood pressure, if used properly, with collaborating between you and your clinician, this can be safe and effective.
Yeah. And that's really good to hear, because the fear is that even if in the moment your heart and cardiovascular system is fine, that over time that extra stress would do harm to it. But what I'm hearing you say is the evidence suggests that that's not happening. And listener, you're aware of the outlines, the homework that I asked my guests to do, our guides to do. They show up with a little map for us. You've written down here something about how drug holidays are common for stimulants. Can you talk about that a little bit?
Yeah, of course. So this is a common topic that we try to discuss at work, where these are medications that can build tolerance with time. In other words, these are medications that, if taken for a long time, the body can get used to them, leading to needing stronger and larger doses and strengths of these medications, which can lead to other challenges and risks. So, because when we find a medication, a stimulant that is so life-changing, we want to protect and use that effective final treatment as long as we can and you breathe. We want to prevent or mitigate the possibilities to build tolerance.
Yeah.
And that's what we call taking a drug holiday. So it depends on people's logistics, weeks, etc. But for the most traditional work or school schedule, we recommend folks that, let's say, once a week, once every other week. Some folks or clinicians, they do a little bit longer or different frequencies, but to take a day without the medication. Some folks even do a week or a summer. But typically, even if taking one day a week or one day every 2 weeks to help the body reset a little bit is already something helpful to prevent or mitigate building tolerance.
Yeah, and I know that's especially common for folks who find that the impact of their ADHD is more severe when they're either at work or at school. And oftentimes they'll find they don't need the assistance of stimulants. If you're just going to be like, if you're, 8 years old and you're just playing with your friends all day, like the ADHD symptoms are less impactful to your daily functioning. Or if you're 38 years old and on Saturdays you play Baldur's Gate all day, then like you might not need your stimulant for that. Or you might, I don't know, depending on what the difficulty settings you have set up.
Yeah, and we have that kind of conversation. So we talk about, hey, if we look at our schedules and we look at the rest of the month, is there a day where you think it's going to be a chill Sunday, where you're going to be at home watching TV, reading, or whatever laundry or things you want to do that may be tolerable or doable without the medication? Because these drug holidays are helpful to keep us in check.
Right.
What do I mean with this? Whenever folks do skip the medication, it tends to be a marked difference. It tends to be a different day, which allows us to continuously revise and review the treatment. As in, is it making a difference or is it not? Are the days where I take the medication and when I don't different? The answer should be yes. Right. So it helps us keep the treatment in check and make sure that we're moving in the right direction.
And this is part of the reason why I get so I love stimulants. Oh boy, shouldn't cut that out of context. But is because you can check in on their efficacy so easily. It's really easy to check and say, is this still working for me? Stop taking it and pay attention to the difference. It's really is that straightforward. And that's not true of all medications.
Right.
So within that category of stimulants,
Yes.
We've kind of got like two broad versions, right? And those are the amphetamines and the methylphenidates.
Yeah, that's right.
And now, having grown up in a town in rural Oregon in, the early 2000s, both of those words sound like methamphetamine to me, which is a very scary thing. What's that about?
So it's a good question because, as you mentioned cocaine before, you are now bringing up another stimulant. Now, all of these are stimulants as a broader category, but they are all different from each other. So coffee, cocaine, meth, amphetamines, and methylphenidates are very different from each other, which even if they sound a little similar and they might share a detail or two, they are very different drugs and should be very different in effect, in tolerability, and in safety.
Right.
We do not find the long-term use or even short-term use of cocaine or meth to be very safe.
Right. So part of the reason that they sound so similar, and I know this freaks people out, which is why I'm slowing down on it. Part of the reason they sound so similar is because within chemistry, there are naming conventions that go with certain kinds of chemical makeups. If we used the sort of technical scientific names for animals, then the difference between a wolf that is a dangerous creature that you want to give a lot of space to and a dachshund is very little. Both of those names are very similar. I don't have them off the top of my head. Maybe while I'm editing, I'll drop them in so people can hear the difference. But Editor Tyson here. The scientific name for the gray wolf is Canis lupus. In contrast, the scientific name for all domesticated dogs, including the dachshund, is Canis lupus familiaris. That's kind of what we're working with. People can get freaked out by the word methylphenidate or the word amphetamine because of the connection to methamphetamines.
That's right.
But that naming convention is because the molecules involved have similarities, similar to how a dachshund has genetic similarities to a wolf.
Yeah, you're actually inspiring me of thinking of something extremely similar. So I'm thinking of birds, right?
Yeah.
So a pigeon, an eagle, a penguin, and an ostrich are all birds, and they couldn't be more different from each other.
Right. Yeah. So yes, they are stimulants. They are in a related category of drug, but they are very, very different in practicality.
That's right.
Yeah. If I was walking to the bus and there was an ostrich on the sidewalk between me and the bus stop instead of a pigeon, I would have a very different morning.
Yeah. In fact, let's bring that up. Let's explain what is the difference, for example, between amphetamines and methylphenidates.
Yeah.
So amphetamines are one of the drugs that do stimulate more release of dopamine and norepinephrine from neuron A to neuron B.
Okay.
So they stimulate a lot more of that release, and they also inhibit the reuptake. So those little collectors that are recollecting the leftover neurotransmitters and bringing them back home to neuron A, they are told to take a break so that there is more norepinephrine and dopamine left, so that neuron B can still have chances to get a little bit more.
Gotcha.
So they have that dual mechanism, if you will.
So to use the pigeon analogy from the SSRI episode, you're both releasing more pigeons and you're telling the guys who collect the lost pigeons, take the day off. You're doing both of those things.
Yes.
Cool.
Whereas methylphenidates, they are more of the second mechanism, if you will. Okay. They are more of the inhibiting the reuptake, telling the collectors to take a break. They don't
Gotcha.
particularly have a strong effect in telling the first neuron to release more dopamine or norepinephrine. So
Gotcha.
both drugs are different and they are both used for similar reasons.
Gotcha. And then the most common versions of those drugs that people know are probably Adderall and Ritalin.
Yeah.
And Adderall is an amphetamine, Ritalin is a methylphenidate.
Yeah.
And different people respond differently to them. Is there any like standard operating procedure of like which to start with or like anything?
This is the question that if you ask on a psychiatry table will require us to order pizza, drinks, and tell our spouses that this will be a long night because we're going to be talking here for a while, let me tell you. Okay. So here's the thing. Everybody has a different opinion on this. Everybody has different experiences with them. The literature is mixed. When you read certain papers, certain textbooks, certain trials, they have favored one over the other one without a very consistent consensus. So to this day, we consider both of them first line. And based on what might also be happening with that person, as in medical history, as in possible co-occurring mental health themes like anxiety and whatnot, we might prefer one over the other, but there's not a strong consensus that will put everybody on the table in agreement with saying, yes, this is the one that we start first.
Right.
Now, it's also, as you mentioned, people do respond very differently. So, Tyson, I can have a day where half the day, all morning, I see patients or clients who tell me, dude, I never want to take an amphetamine again. This is the worst thing that has happened to me. But methylphenidates, let me tell you, that was my life changer. And then after lunch, I see other folks that tell me, dude, do not even mention methylphenidates. I will never take a methylphenidate again. But let me tell you, the amphetamines changed my life. And you just, you just hope for the gods of psychiatry to enlighten you.
Yeah. But when you're getting started, you just kind of have to feel it out.
It's hard to predict because everyone's body's genetics, metabolisms are different, and they will play a role on how these will be tolerated and how this will create response or an effect that we desire. But both of them are first line. And what we do, though, is we hope that the first one works. We choose it based on other factors like medical history and mental health history. And we hope that the gods of psychiatry are on our on our favor, and we see what the patient or client says. We always want them to be our compass. We follow them as our guides.
Yeah, and which I feel like I'm gonna say this at least 2 more times in this episode, but which brings me back to this theme that's come up every time we've talked of like, talk to your prescriber and prescribers will listen to your feedback. I feel like so often, especially in situations where people got their prescription from a primary care physician who had a very booked schedule and didn't have a lot of time to talk, or when people experience these medications as children, where it was mostly the adults having conversations about them, people's sense can be, oh, this is what the doctor told me to take, I'll just do what the doctor says, and then, oh no, it didn't work for me. But one of the themes we come back to over and over again is this is a dialogue, right? Like your prescriber knows more about these drugs than you do, but you know what your bodily experience is. And that's the primary source of information about whether or not the drugs are helping.
And that is the theme of psychiatry, Tyson, because in everything else on the body, pretty much everything else, not everything, but most things, we have other tools where science has done tremendous progress. So let's say you have a lung infection, and we can listen to it. We can take X-rays. We can even do I don't know, blood draws to see how markers for infections are. We have all those tools. And then after we use a remedy, we see that the X-ray cleared up, that they sound better, that you breathe better, and that your blood markers have normalized. But in psychiatry, we need you to tell us. Look, there are observable behaviors, don't get me wrong, but what the person says should be our ultimate compass, and we should see what they feel, what they think, what are the impacts that these medications are having.
Right. Yeah. Yeah. So if you're listening to this, listener, and you're interested in trying these out, be in conversation with your prescriber, because that's the only info they have. So let's talk about the non-stimulant options.
Yeah.
So those are the stimulant options. That's first line. That's what everyone tries first. But there
Yes.
are non-stimulant options for ADHD. So what does that? What's the deal with non-stimulants? Why would people go there, and what are they?
There are various reasons, but two are the most common to try a non-stimulant. The first one is preference. Some people, based on ideas, philosophies, backgrounds, or, straight up preference, they don't want to try a stimulant, which that's fair game. And we will respect that, and we will try something else. The other possibility is we are either getting an optimal or partial response on a stimulant, as in the symptoms or the themes have improved, they've improved, but maybe not as much as we're hoping. There's some room for improvement still. Or the tolerability is not great.
Right.
So either because the stimulant is not working as intended, or by preference, we may try non-stimulants. And these have also two families.
Okay.
Now, why are they second line of treatment? They are very well tolerated. In fact, they're most of the time better tolerated than stimulants because they're gentle. But they are second line because their effect tends to be weaker.
Right.
It doesn't mean that it's negligible. It's weaker. And this goes back to one of the first things we said, which is the effect that stimulants have as a treatment is hard to match.
Yeah.
Because of how they're just so good at what they do. But non-stimulants work, and they're amazing, and they work on themselves, and they also pair up with stimulants very, very well.
So some people will use both.
That's right. They pair very well for two reasons. One, they can address different themes or symptoms of ADHD. So, for example, non-stimulants are, based on the research we've had, better at emotional regulation, sometimes at parts of executive functions like planning, organization, or time management. And sometimes they can be better at task shifting, which is when we're going from one task to the other one, where most neurotypical folks can finish task one with whatever tab they have open on their internet, close it, and move to the second one. But sometimes that might sound simple for neurotypical folks, may not be for others. Right. So non-stimulants are very effective at other themes, and their main side effect is decreased blood pressure and decreased heart rate. Which means that they complement each other very well.
Interesting. So do people ever take the two together, like in part to manage the increased blood pressure issue?
They can.
Huh.
They sure can. And if, let's say, we are working with someone who does have a history of cardiovascular concerns, we do the proper things. We consult with a cardiologist. We do everything that we might do.
Sure.
And let's say that the stimulant is working very, very well. And their blood pressure is not concerning, but it's a little higher than we were hoping for, and we want to keep them safe. Maybe our judgment, collaborating with a cardiologist, might be beneficial to use a medication to decrease their blood pressure that will enable them to continue their ADHD medication. In a risk-benefit discussion, the ADHD treatment is working so well, but we still gotta watch for that blood pressure. We might use one of these medications that lower the blood pressure that also have effects on ADHD themes. So they are a dream team, let me tell you.
Yeah. So what are these two different non-stimulant categories? Like how do they work? If they're still are they still targeting mostly the same neurotransmitters, still dopamine and norepinephrine, but in different ways?
Yes, that's the end goal in general. So the first family, the family that can lower our blood pressure and heart rate, these are what we call the alpha 2s. In particular, the name is alpha 2 adrenergic agonists. So what they do is they stimulate these particular receptors, these alpha 2 receptors, also in the prefrontal cortex, which will modulate, balance the release of dopamine and norepinephrine.
Oh, interesting.
So we're working with the same neurotransmitters, just in a different way.
So what I'm hearing is that whereas the two stimulant categories are kind of about increasing the amount of these transmitters that are just out there in the brain, this one is about keeping that amount more consistent.
Yes.
It's not about sending out waves of them at once or about not bringing extras in. It's about making sure that it's a steady flow.
Yes.
Interesting. Okay. So what does that do?
So that's a good question. So what we see when we observe with this consistent modulation is that some of these symptoms that might not be the same ones that stimulants are targeting, like that hyperness, the hyper movement and activity, the hyperfixation, the inattention, these that might be more stimulant targeted, are not so much targeted with that modulation. But what we see is more modulation of those downstream effects that we were mentioning before, with a little bit more cooling down, where things slow down with a little bit more emotional regulation, with better control at task shifting, with better control at planning. So we see very different things at modulating the release of dopamine and norepinephrine versus stimulating it versus inhibiting the reuptake.
Right. So just like intuitively, based off of how we're talking about this working now, which I'm aware, very, very very simplified, but it feels like this category, which by the way sounds like the name of like an alien faction in like a multiplayer like real-time strategy game, right? The alpha 2 adrenergic agonists. Yeah, is that right?
That's
I
right.
don't know.
Yeah.
Great. It feels like this would be an ideal like co-medication or co-therapy to go with a stimulant. Like it feels like those two together might make a pretty dream team for some people.
Yeah, they do. And it's a very, very common combination. So what we see a lot of times is that stimulants may address the primary concerns, impairments, or goals that a client or patient may have. And they do well on the stimulant, and good for them. Amazing. For some folks, the stimulant might not be working as expected, or the stimulant might be working as expected on, let's say, attention, impulsivity, and hyperactivity, but they are still experiencing challenges on other areas where non-stimulants might have a greater effect. So in those cases, we do recommend possibly combining these two and getting a little bit of both worlds. In fact, sometimes these are or can be folks with coexisting anxiety, for example, coexisting trauma themes. And because these medications can lower things down, they do lower blood pressure and heart rate. Subjectively, we feel a little more relaxed. So we address ADHD symptoms, we mitigate cardiac side effects or that can be possible of stimulants, and we might be also helping some of this anxiety and stress regulation.
Because I have heard from folks before who were on stimulants that it could sometimes trigger an anxiety response, right? That's common to hear about stimulants, right? There are many people who have to stop drinking coffee because they start getting panic attacks because they were drinking too much caffeine, for instance. And it sounds like this could be a way to try to mitigate some of that. Or like, do people sometimes take these non-stimulants for not to treat any ADHD symptoms primarily, but just for the anxiety relief?
They can be used for many, many themes, including anxiety, withdrawal. Even at times we can use them for nightmares or many other regulatory or emotional regulation themes. So they have many uses. They're lovely, let me tell you. And very importantly, a fact that I haven't mentioned so far is that all of these categories, both families of stimulants and both families of non-stimulants, have generic versions. Right. So these are lovely meds that can be accessible. They don't have to be, they don't have to break the bank, if you will.
Right. Yeah. Yeah. They're decently easy to afford to come across. So the other category of non-stimulant, this is a little familiar, selective norepinephrine reuptake inhibitor, as opposed to a selective serotonin reuptake inhibitor. This leads me to believe that this category of drug might work very similarly to SSRIs, just with a different neurotransmitter.
Yeah, that's right. So they primarily focus norepinephrine, which will be one of the neurons that contribute to what you were mentioning earlier, related to motivation, engagement. They do have, a minimal secondary effect on dopamine and even milder effect on serotonin. So we are working with similar neurotransmitters.
Gotcha.
However, because we are affecting norepinephrine, these medications can also lead to increased blood pressure and heart rate. This doesn't mean that we can't combine them, but it probably means that we want to take maybe some extra steps. So those might be patients or clients where we ask them to check the blood pressure and heart rate at home a few times a week. We ask them for maybe this or that kind of checkup. So they might take some extra steps, but we can and often combine them. I just want to make a difference that one of the non-stimulants decreases blood pressure and heart rate, and the other non-stimulant, the current SNRIs, can increase blood pressure and heart rate.
Gotcha. And it looks like the SNRIs, like SSRIs, can take a little while before they kick in. So unlike every other drug we've talked about today, this is a category that actually you don't see the effects immediately. You do need to be more consistent with it for it to affect.
It probably takes a few weeks, which it doesn't mean that it's not worth it, but it will probably require a little patience. We're still going to aim for the same non-stimulant benefits, but it might take a little bit of patience, and hopefully we make it through those few weeks and see the benefits of combining stimulants and non-stimulants.
Yeah. Okay, so we've talked about the sort of two major categories, stimulants, non-stimulants, and the two kind of like subcategories within those. So 4 categories, right? We've got amphetamines, methylphenidates, alpha 2s, and SNRIs. Those are sort of the 4 options. Just very broadly speaking, someone's got a sense, okay, these are the meds, this is kind of how they work, this is what they do. What are your general recommendations for someone who's interested in getting started with medication to treat ADHD? How do you coach them?
Yeah, great question. So the first thing that we will always emphasize, start low and go slow. Mm-hmm. Let's play this with our end game goal to be playing the long game, in other words. For our end game to be finding a treatment that we can use for years and years so that we can address these themes, impairments, or challenges, and overall improve our lives. So let's start with a little baby dose. Let's see how our body reacts. Let's see how we tolerate it. Let's see how we respond. And we can always continue making adjustments. But let's start low and go slow. Let's be gentle and have a little bit of patience so that we can play the long game.
Mm-hmm. Mm-hmm. Take your time.
Yeah. We want to be mindful of when it might be beneficial of combining stimulants and non-stimulants. Mm-hmm. We want to be mindful that some folks do take some of these medications that contribute to what we call the afternoon crash, which for a lot of people, our amount of energy throughout the day can feel progressive and curbed. But for a lot of other people that meet the criteria for ADHD, we can feel like instead of a gentle curve of energy, as an abrupt fall in energy, which can feel very unpleasant and it can catch people off guard. So that is something that we should be monitoring and being mindful of and see what we might be able to do. Possibly adding a non-stimulant, possibly adding a different dose of a medication to prevent that afternoon crash. We want to be mindful of coexisting themes like anxiety. We want to be mindful of tics because some folks, particularly children, their tics can be exacerbating on these ADHD medications. So we want to be mindful. We want to minimize side effects and work collaboratively. Just like I said, follow the patient or the client as your compass. Listen to what they're saying and see how you can work together to achieve their goals.
Yeah. So as we are kind of coming to the end of this conversation, would you say something about like the role of psychotherapy in ADHD treatment? Because I often see people wanting to either do one or the other. And as comes up every time we have a conversation, as I recall from what you've said, the research is pretty clear that like psychotherapy and medication are a dream team.
Yes.
Putting them both together makes everything better. Choosing just one or the other, you will see benefit, but making use of both will almost every time we look into it lead to a better outcome. So what's the role of psychotherapy in ADHD treatment, especially if someone's actively taking medication as well?
I cannot stress this enough. I will put my psychologist hat on because this is half the game. Medications and therapy are a shoe for each foot in this marathon of recovery or healing. Okay. So medications should contribute to an important effect, but psychotherapy will help readjust to the effects of the medications in a way how physical therapy can help somebody that started recovery for a physical, let's say, ailment in this case. In other words, somebody might be getting a treatment for back pain, good for them. Maybe they're getting a medication for back pain. But physical therapy will be very important in their long-term response and sustained recovery. A lot of folks, they have this new way of feeling and processing informations and emotions with this medication, and it can feel odd. It can be unfamiliar when things and the noise slow down, when the noise goes down. And that might require relearning how to drive that car with the new brakes. So now when we're taking the twists and turns, when we're managing the speed, and now we have brakes that are working as we were hoping for, it will take a lot of behavioral intervention and support to figure that out. The medication will help the brakes, don't get me wrong, but you're going to have to be driving that car.
Right. Yeah.
And that will be a lot easier if done in psychotherapy.
Yeah, because I see a lot of people, especially with ADHD, I see a lot of people trying just the meds to address it, which I get it, right? It takes you maybe 5 seconds to take your meds every day, and like psychotherapy is usually more like an hour every week or two. Like it's a big difference of time, and it does feel like psychotherapy can be a really useful space to adjust to the fact that now your mind is functioning very differently than you used to. Right? Like,
Yes.
You're no longer using the same mental patterns you were before. And if you want to change mental patterns, taking medication doesn't do it. Right?
That's right. Let me give you a clear example to put it in more concretely. Often, folks who developed or grew up with ADHD might experience a lot of impulsivity, blurting answers, interrupting others, maybe not waiting for their turn, maybe acting spacey when people are talking to them, which can lead them to feel socially anxious. It can lead us to feel like we are bothering other people, or that other people might find us dumb or incapable. And if that's happening once or twice in your life, most people can bounce back. But if that's our theme, day and day and day after day, growing up, it's very reasonable that we're going to start to likely feel a little socially anxious. Now, let's say now we are 25. We are diagnosed. We got a medication, and these symptoms feel so more manageable. Tyson is amazing. But hear me out. This person now goes back to school or work, but they still feel socially anxious. They don't have those ADHD themes anymore. They don't feel like they're interrupting everybody and feeling impulsive. Those things now feel better addressed. But their inner narrative and experience of social anxiety will be something that should be adjusted, addressed, and healed through this therapy. Whereas now we can drive the car better, and we don't have to be worried about, oh my gosh, how am I going to take this curb? If I can't brake, I'm going to do it like this, like that. But actually now the car works fine. Why am I so anxious about it? Let's talk about it.
Right. Right. Yeah. 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 Because the human mind is not just the way that the neurons interact with one another. It's also the procedure.
Yes.
And those procedures and processes are changed through intentional, effortful practice. And like we say with children, right? Social development is emotional development. They're one and the same. So a lot of times changing those mental procedures is a process that's done in some kind of active relationship. And that's where psychotherapy comes in, at least as I think about it and practice it.
So it's very important for the adjustment of these situations. And because many times, like the social anxiety example, the medications, when effective, can unmask coexisting themes. So now these symptoms are addressed. My ADHD is now in remission or responding, but I'm still depressed.
Yeah.
I still have 15 years of low self-esteem.
Yeah.
Let's talk about it. We don't have a medication for self-esteem.
Nope, we don't. Well,
we need to talk about it.
on a very, very short-term basis, certain stimulants certainly have a positive impact on self-esteem, but not in a way that's clinically sustainable. We'll put it that way.
So it's very important, like in every other mental health theme, to combine psychotherapy and medications to not just notice an improvement halfway. We don't. We can do better. We can do more. We can get all the way there and feel very differently than we have felt before, maybe undiagnosed and untreated.
Yeah.
I think the most important thing, I'm just going to be reiterative and repeat what you say, which is let's talk. Let's talk about everything that's going on to understand what we can do about it, to help me help you, so that I can be the best clinical guidance that I can be for you to achieve your goals.
And one of my hopes for these episodes that we do is that, yes, that anyone who might be thinking about, or anyone who's curious can just learn about some stuff, but also that anyone who is actively seeking medications to treat whatever it is that they're dealing with feels like they're equipped to be able to have the conversation a little bit more, right? The goal of this isn't that you now have your, you listener are not now a qualified like nurse practitioner, psychiatric nurse practitioner, but that you listener now feel like you can have that conversation and feel a little bit more equipped to go into it saying like, okay, I heard this thing about it. I'm experiencing my appetite's reduced. Oh, maybe that's connected to my meds. I can talk to my prescriber. And like we've been saying, like talk about it. Talk to your prescriber, talk to your therapist, keep the dialogue going, because it's in that dialogue, it's in that relationship that people get better. And the medications are not separate from that dialogue. They're part of it. That seems to be the thing that we keep on saying, and we'll keep on saying it.
Let me tell you, how you mentioned that dopamine feels good? When patients and clients improve, let me tell you, every clinician gets a hit of dopamine.
Hell yeah. Very true. Very true. So, what would you like to plug? Where would you like to be found for our listeners?
Yeah, if anybody wants to learn more about these medications, they can go to my website, which is cogniahealth.com. We've been building a resource page with informations on mental health themes and conditions, and a long list of medications, probably like the 40, 50 more common medications in psychiatry, with good handout and educational information of pretty reliable resources for you to learn more about them, because the internet's a weird place. And these are reliable, scientifically proved sources of information for you to check and learn more about these medications and how they may help you out.
Yeah. So if people are interested in working with you, they can go to that website. Or if they're just interested in learning about stuff, you're building that library of more. If you're loving this conversation and are like, all right, great, now I want to learn about more things without waiting for the next episode to come out, check out the website, and it will absolutely be linked in the show notes. Well, Mati, thank you for another conversation. This was delightful. And we'll catch you again on the next one.
Yeah. Thank you, Tyson.
Special thanks to Matias Massaro. Mati's contact information can be found in the show notes. And with that, listener, that's our final episode of this first season of The Way In. We did it. I got them all released. Almost on time, too. Woohoo! I'd like to extend a very special thanks to Ben Lewis and Dan Lane for their creative contributions to this show. Without Ben's music and Dan's artwork, I don't think this show would be half of what it is. I'd also like to extend a thanks to all of my guests. Thank you for coming on to this untested and unproven show, and I hope that the final product of each of these interviews has been something that you feel reflects your skills and expertise well. And finally, most of all, thank you to all of the listeners, whether this is your first episode or you've been following us since the trailer dropped. I hope that you've enjoyed listening to these as much as I've enjoyed making them. And I hope to be in your earbuds again soon. Don't know exactly when. It's a small team here making this show. But thank you, listener. Until next time. This has been The Way In. This show is hosted and produced by me, Tyson Connor, with music by Ben Lewis and visual art by Dan Lane. If you enjoyed this show, please rate, review, subscribe, follow, like, share, star, heart, reblog, retweet, repost, upvote, or in some meaningful way engage with the episode on your digital platform of choice. I'm told it makes a big difference for exposing more people to the show. And if you think someone you know may like this episode, you could also just tell them about it. You can follow the show on social media, where we are at The Way In Pod. There you can give me feedback, tell me a joke, and see high-resolution versions of the individual episode art, which I highly recommend. I think Dan did a great job. Thank you for joining us. Until next time.